चिक चिक, ठीक है, लेवल चिक 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 चिक, हेलो, फुल कर, चिक चिक चिक, लो, लेवल ठीक है क्या? चिक 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 चिक, चिक चिक, हेलो, चिक 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 चिक, ठीक है,
Really, it was a hell of task to call all the individual who have established themselves into the respective field. It's a very tough task. But I have tried my level best. Whatever I have achieved, become the real world God. We have not seen the invisible God, but definitely we have seen, we are watching, we are talking, we are mixing on day-to-day basis with the real world God. For that, I'm really delighted for the God that they have given me the opportunity for the same. I have started this, I am having the idea to do this CME in a different way. I got the opportunity. I have thought that probably the old is gold. Still, आज भी जब पुराने गाने बजते हैं, आप कितनों डिस्टर्ब रहिए, तो आपका सारा चीज़ जो है वो सिंक्रोनाइज हो जाता है। तो इसलिए जो फर्स्ट टॉपिक that is sulfonylurea, we are going to unfold through the international reputed speaker, none other than Dr. A.K. Singh. Sir, I will take 2 minutes time more. Today what I am here, I am standing in before you with my effort or the blessing from all of you. What we have made the journey for 3 Dots Life Science, I wanted to show the visual clip for 2 minutes. Please bear with me, please.
किसी भी इवेंट के लिए
On 8th February, we have done the Bhumi Pujan in Sakri Industrial Area. I'm remembering the one word from Dr. Sudeep Chatterjee sir, the renowned endocrinologist of Calcutta. He said the people is getting the business from their own state, but they are shifting in other state. So please इस बात को आप याद रखना कि जब भी कुछ करना तो बिहार के लिए ही कुछ करना। जब बियाडा के डायरेक्टर साहब से सर बात हुई तो उन्होंने कहा कि बिहार में आज तक क्यों नहीं फार्मा कंपनी ग्रो कर पाया। हम कहे सर रिलक्टेंसी फ्रॉम द योर एंड, रिलक्टेंसी फ्रॉम द आवर एंड, दैट इज द ओनली आंसर आई कैन से। कोई भी स्टार्ट करेगा तो उसको तो टफ होगा सर। तो मैं 14 नवंबर को मेरे को ये ज़मीन अलॉट हुआ था। नाउ प्रोडक्शन डेट इज़ फिक्स, दैट इज 14 नवंबर 2026। थैंक यू सर, थैंक यू। नाउ विद दैट ऑफ दिस CME 2 पार्ट में है, एक इनॉग्रेशन पार्ट एंड देन एक CME पार्ट। For that, I have asked my elder brother support, Dr. Arvind sir, to please conduct the same, sir. Please.
First of all, I must congratulate you and God bless you. All the best wishes. Let us start the inaugural ceremony, for which I have privilege to invite our inaugurator, Padam Shri, Dr. Hemant Kumar, President AIMS Gorakhpur and ex-HOD Nephrology IGMS. Hemant sir, please come on the desk. Then I invite our chief guest, Professor Dr. H.K. Singh, ex-HOD Department of Endocrinology. दरवेश जी सर को एस्कॉर्ट करके लाइए. Then our guest of honor, Dr. S.S. Chatterjee, past President CSI Bihar, ex-Director IGIC Patna. Sir, please. And guest of honor, Dr. Professor U.S. Roy, ex-HOD Department of Nephrology, IGMS Patna, my teacher. Please, sir. Requesting Mr. Darvesh Jha to please honor our guest by presenting bouquet. May I request Dr. Sanjay, Dr. Ranjan, Dr. Sudhir, Dr. Kunal, please come and one by one present memento and sol to our guest. मैडम ये आप वो ले लीजिए सर के साथ जाइए आप ले लीजिए एचके सिंह खोल के दीजिए खोल के रंजन खोल दीजिए उधर देखिए सुधीर सामने we will request our inaugurator, chief guest and guest of honor to kindly inaugurate this function with lighting of the lamp. Darvesh ji, please arrange for the lighting of the lamp. And in the background, Saraswati Banna should be started. Audio visual team, please start Saraswati Banna.
Ya kundendu tushara haradhavala ya shubhravastra ya veena varadanda manditakara ya shveta padmasana या ब्रह्माच्युत शंकर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभय.
Please take your seat, sir. May I request one by one to our guests to say a few words to bless these occasions and to the, T. Life Sciences with your kind words. Hemant sir, please.
Good evening, everybody. My teacher, Professor H.K. Singh on the dais, my friend, Professor U.S. Rai, my senior, Dr. S.S. Chatterjee, in the hall, my senior, Dr. Ajay Kumar, sir, Dr. Bijay Achari, Dr. B.P. Singh, Professor Om Kumar, and all dear friends and my seniors. Today is definitely a landmark day that we have gathered here as triplet. We have seen twins, but today we are triplets. Diabetes is such a disease that it has created a triplet, including endocrinologist, diabetologist, nephrologist, and a cardiologist. So I will like to thank Mr. Darvesh Jha, particularly for this association of today's evening, that he has invited all these consultants here to gather and share their views. And I have not named Dr. A.K. Singh. I know him only because he has been treating my elder brother in Kolkata, and I'm seeing him after almost 2 decades. So this is a very good association that we have gathered here, and we are going to discuss a very important, Darvesh has already told that old is gold, so that is well appreciated here today. It will be seen in the talk of Dr. A.K. Singh. Thank you very much all for this gathering. Thank you.
Thank you, sir, for your encouraging words. My request, Professor H.K. Singh, sir, आप वहीं बैठ के, sir.
Good evening, everybody. Our guest speakers, Dr. Avdesh, Dr. A.K. Misra, here from Jamshedpur, and Naveen, Padma Shri awarded, and all the majority are my students. So I am running 86 today. 86 years. And this Darvesh था पहले पैन एशिया का हेड, इसको नॉर्थ कोई इंटरनल डिफरेंस में ट्रांसफ़र कर दिया, जो स्टेटे बदल दिया। दरवेश जी को शायद याद होगा, आए मेरे पास, हम कहें ये रिजाइन करो और कंपनी खोलो, आज जाओ A.K. ठाकुर के यहाँ और S.N. मिश्रा दोनों थे, उनके कार जाके पूछो ये कौन प्रोडक्ट लिखेंगे, वही प्रोडक्ट बनेगा। और उसने किया, हम उसी समय फोरकास्ट किए थे 3 साल लगेगा तुमको मेकअप करने में। 3 साल में आप पेमेंट देने के बाद बचत खाता में जाने लगेगा। Then the CME, I started very long time CME. Today I was searching files. So in 67 में भी मैंने सिम्पोजिया किया है, और उस समय ड्रग्स केवल क्लोरप्रोपामाइड, डायबेनीज एंड DBITD, एंड 51 में निकला आपको टॉलब्यूटामाइड. They will give the history of the past, present. So I don't go in detail. I have worked 2 years for the Dianyl. It was a code, 420 code, I remember, by Hext Pharmaceutical. And I joined as a PG, 67, I was PG student. and that just like a बतासा अगर देखें वो छोटा वाला तो उसी साइज का टैबलेट था, लेकिन 67 to 69 2 years का रिसर्च किया, रिपोर्ट दिया, डाइनी लाया है 72 के एंड में, 73 में मार्केटेड हुआ इन द नेम ऑफ डाइनी। एंड क्लोरफॉर्मिन एंड ये डायबिनीज, इसका सिंपोजियम करते हैं लेक्चर थिएटर नंबर 1, और उसमें यूएस भी जो है उसमें कोल्ड ड्रिंक का एजेंसी था, वो ट्रक लगा देता था कोल्ड ड्रिंक का, और स्टूडेंट फर्स्ट ईयर का हो या फाइनल ईयर का हो, सबको फ्रीडम था जितना पीना है पी। ऐसे रन किया। फिर आपको मैंने ग्लाइकोजाइट पर भी ओरिजिनल रिसर्च किया, डाईमाइक्रोन आया, कल रिलीज हुआ कलकत्ता में ताज होटल में, उन दिनों उसी का क्रेज था। और उसके बाद फिर रिक्लाइड पर भी ट्रायल किया। रिक्लाइड के ट्रायल में सीरम, दिलीप सेन को कहा कि सीरम इंसुलिन स्टार्ट करिए, तो कई ठो केस दीजिएगा, हम कहे हम आपको 4 व 5 केस डेली देंगे। तो सीरम इंसुलिन सी पेप्टाइड, हम कहे 2 टेस्ट करिए, दो आई थिंक मोर देन 2 lakhs rupees paid by Reclite people to him. So in this way run, and CME में श्रोता स्ट्रांग होना चाहिए, वक्ता और श्रोता दोनों का कॉम्बिनेशन ठीक हो तो सब ठीक रहेगा। अवधेश जी बहुत अच्छे स्पीकर हैं, इसलिए आई हैव हर्ड सेवरल टाइम। हमारे यहाँ भी अभी भरमार है स्पीकर की, बिहार में कमी नहीं है। डीएम नेफ्रो, डीएम कार्डियो, डीएम endocrine, and so many cardiologists and diabetologists here. So with this, I don't want to longer this. I request the organizer to.
Thank you, sir, for your blessings. Now may I request Professor U.S. Rai, sir, to come and say a few words.
Respected ladies and gentlemen, and all the dignitaries sitting on the dais. Today we are here to discuss the sulfonylurea, past, present and the future. I want to thank the organizer, Mr. Jha, to keep such topic for the discussion. We are very much excited, especially to know the future about the sulfonylurea. This is one of the drugs which has played very important role in the management of diabetes in the past. Not in the past, even nowadays it is most widely used because of the most cost effectiveness. So with this, I don't want to take more time. Thank you very much.
Thank you, sir, for your valuable words. May I request Professor Dr. S.S. Chatterjee, sir, to say a few words.
Good evening, everybody. Dr. Arvind, I'll correct him. I have never been a professor, so that must be
sorry,
very
sir,
clear.
by mistake.
Doesn't matter, but I'm really very impressed with the gathering and with the efforts that Mr. Dharvesh Jha has taken. I have seen Dharvesh for a long time, since he was a medical representative. And I have seen those days, and I have seen him now, and I have seen his efforts and sincerity to his profession and then to his business that he established. I wish him all the best, And I have seen the place where he has established his industry, and I'm very sure, and that then he assured me that he is going to have, it's a WHO and GMP certified products that will come out from here, and he will not produce, that is what he told me, I suppose he stands by that, he will produce only those drugs which will be marketed by his company in the beginning at least. Beyond this, I must say that I am here very, very pleased and very honored to share dais with Professor H.K. Singh and with Professor Lalit Kishore Prasad. These two persons had been my teachers during my house job, so I still remember. I have learned from them. And then two stalwarts, the people who started nephrology and urology at IGIMS, Dr. Hemant and Dr. U.S. Rai. So we'll have a very great evening. We'll hear many things, and let us see how it proceeds. And my congratulations and good wishes and everything to Mr. Dravesh.
Thank you, sir, for your kind words to encourage Mr. Dravesh Jha and his team. Now the inaugural ceremony is over. I am handing over the mic to Dravesh, to moderator. Yes, sir. I request our guests to please come and take the front seats. And may I invite our today's scientific program's moderator, Dr. S.K. Singh, Santosh Kumar Singh. Sir, please come and sir, start scientific programs.
Respected seniors, dear friends, it's a real pleasure to be on the dais today. I wish Three Dots all success and to emulate what has been achieved by Son of the Soil, who has gone international. And I wish, and I am sure, Three Dots will do the same. Son of the Soil, going to the international arena, and I won't take much of your time. Only thing I would like to share, when you are not able to achieve something, you always want to achieve in your peers. And this is what applies to me with regards to all this. Whenever I see a paper of him, I am so elated with his achievements. It seems it's my, what to say, contribution or whatsoever. So with this, we will go to the CME proper, and with the present day emphasis on the CKM syndrome, we have cardiologists, we have nephro, and because of the increased metabolic risk factors, we have two from that side. So from that, my privilege to call Dr. BP Singh sir over the dais. Cardio part, and Dr. Om. Anybody's guess, it is a nephro, and two persons will be dealing with the metabolic risk factors, Dr. Vijay Achari sir and Dr. Ajay sir. So now the dais is yours. Thank you.
Good evening, ladies and gentlemen. Patna, Bihar is privileged today to have Dr. A.K. Singh. Introducing Avdesh to this audience would be an audacity because he has been coming here so frequently that every physician knows him. But even then, I would like to speak a couple of words about him. For an Indian to be on the editorial board of Williams' textbook of endocrinology is not a mean achievement. To write hundreds of papers in quality international peer-reviewed journals is also not an ordinary achievement. And to be respected as a national and international speaker is icing on the cake. And that's the brief introduction of Dr. Avdesh Kumar Singh, who is going to be the speaker today on this very important topic. I know for sure that number of new medications like GLP-1 receptor agonists, SGLT2 inhibitors, and so many others have come in the market. They have established themselves and have actually bolstered the therapeutic armamentarium of the physicians. But at the same time, it is really important to appreciate that sulfonylureas have stood the test of time for last several decades. Why? That's what we are going to hear from Avdesh, and I welcome Dr. Avdesh Kumar Singh to the podium to deliver his address. Thank you.
Good evening. Thank you, sir, for the kind words. Always a pleasure. It's always an emotional place for me to come back and stand in front of you. I could see many senior professors, father figures, teachers equivalent, many friends, and future generations looking how we should actually looked at. So many of you may be on Twitter, so I will go a little bit beyond my topic. I will not bore you, I promise you. If you look at the current social media post related to Bihar, when the Prime Minister of the country tweets that send me the Chhat Puja's songs, and if you go to the Prime Minister Narendra Modi's post, with 2.3 billion people liking it and sending at least 2,000 Chhat Puja song, the Bihar is back in the global scenario. So first, a big round of applause. If you look at the Twitter, today every railway station in India, from Kanyakumari to Kashmir, from Simla to Kolkata, is singing Sarda Sinha's songs on the railway station as well as the airport. It has never ever happened in the past. So again, Bihar is back in the global stage. I am happy that on the eve of that greatest festival in the planet, I am back to my roots. And after a long time, I get the opportunity to go back to my native place to celebrate Chhat Puja with my native relatives and the family. Meanwhile, while I was traveling back to my birthplace, which is in Saharsa, I landed back to Patna. I was going through Darbhanga, but Draveshji asked me that, why don't you come here? You go through the Patna. You know, my association with Three Dots Lab goes with Dravesh Jha. When I was the first organizing secretary of IdeaCon, many of you might be knowing, which is one of the very reputed, I would not say the best conference right now in India. He came to me that, sir, I am the CEO of a company called 3 Dot LifeScience from Bihar, and I want to participate in IdeaCon. This is the story of 2012, so 13 years back. I was very happy that someone from Bihar is coming to Calcutta and asking me that he wants to participate. So I, with a folded hand, I grabbed him and said, please come, join us, and land your foot in the eastern part of country in Bengal. And since then, Draveshji has not, looked back, and he is doing marvelous even in West Bengal. I know he is doing great in Bihar and Jharkhand. Now when this program was arranged, I was asked that what topic I should speak upon. I said, whatever you wish. Then asked him who are the people going to come. I heard many senior peoples will come. I thought I will not speak on a latest subject which I keep on speaking every day on a GLT2, GLP1. Let me speak on again when the glory of Bihar is back. Let's look at sulfonylurea, which is the core product of 3-dot life science. And many people really ask me today that in the era of SGLT2 and GLP1, where stands the sulfonylurea? So before I start my presentation, let me tell you, the sulfonylurea has stayed for past 60 years. Professor H.K. Singh sir told us the story of restinone, tolbutamide, followed by chlorpropamide, and then glibenclamide, to then glipizide, then gliclazide and glimepiride. That's the story of simple classification of sulfonylurea. Sulfonylurea was used, starting from the UGDP program, in 1969. Few peoples from United Kingdom gathered together to know whether sulfonylurea causes any cardiovascular problem. I will tell you the story. The fact of the matter is that sulfonylurea was never ever beaten by any newer generation drug in a head-to-head trial. Sulfonylurea fought with metformin, never lost. Sulfonylurea fought with DPP-4 inhibitor, never lost. Sulfonylurea fought with TJD, means earlier Rosi, Pio, now only Pio, never lost. It fought with SGLT2, never lost. The only molecule where it lost was with the GLP-1. So this molecule works, although the sulfonylurea doesn't have any additional ability to prevent cardiovascular disease directly, but by controlling blood glucose, it surely reduces the microvascular complications. So the future will remain with any anti-diabetic drug because no single anti-diabetes drug works. So that's the story of past 70 years of sulfonylurea. You can look here that in 1956, there's a very interesting story how sulfonylurea was discovered. A French physician treating a patient with typhoid disease used sulfonylurea, and patient landed with a hypoglycemia. People realized that this is the drug which has been given for the treatment of typhoid fever is causing hypoglycemia, not the typhoid disease itself. And then people realized that sulfonylurea has a property to lower blood glucose. At that point of time, the first sulfonylurea was discovered. But for the first clinical use, you can see in 1956, the tolbutamide was launched. Tolbutamide undergone a cardiovascular outcome trial and was found to have increased mortality event, and therefore it was banned in 60s. That was the chlorpropamide area, the second, in the list in the sulfonylureas basket. Chlorpropamide also got an earlier death because it causes disulfiram reaction. People taking alcohol with chlorpropamide was dying. So chlorpropamide was banned for several side effects, including SIDH and disulfiram reaction. Then was the glibenclamide era, and you can see the randomized control trial from UGDP to UKPDS to advanced Tosca. It was the Italian study in Carolina where glimepiride was head-on compared with linagliptin. Why we are talking about sulfonylurea? When we knew that it's a wonderful drug and we had experience of past 60, 70 years, why we were concerned about sulfonylurea? That's the first question. We know that's a wonderful glucose-lowering drug. You can see on your left-hand side, it's a very cheap drug. We have got a long clinical experience. As you can see, a person like Professor Singh, who is 86-year-old, started using it, and he is still using it. This speaks volume about the long experience with sulfonylurea. You don't have the problems of pancreatitis, genital tract infection, etc., etc. Sulfonylurea has no problem at all, except that if you use in a, unnecessary dose, it causes hypoglycemia. So barring hypoglycemia, sulfonylurea didn't carry any baggages. And we didn't need to worry about, any other baggages which other molecules might have. However, the only genuine concern was whether it is a cardiovascular friendly or not. So if the drug causes hypoglycemia, it will cause weight gain. It's not sulfonylurea is an anabolic drug like insulin. Because sulfonylurea in a wrong dose, in a wrong patient will cause hypoglycemia, and because of hypoglycemia you will do a frequent snackings, therefore it will cause weight gain. It's not that it's an anabolic drug that causes weight gain. So the genuine concern with sulfonylurea in clinical practice was the cardiovascular neutrality. And where from the issue came is from this first trial ever done in the space of type 2 diabetes mellitus. In 1969, this trial called UGDP program compared, this was the first randomized controlled trial done in the planet, where people were randomized, people with type 2 diabetes were randomized to either chlorpropamide or, tolbutamide or placebo, and you can see in a span of 8 years, it's a pretty long trial, people forgotten that. There was an increase in cardiovascular death, although this number of events and the number of people involved in this trial, but this is again take care of 1969. At that point of time, conducting a randomized controlled trial in a 400 odd patient is, too great, from that point of view. But there was an increase in cardiovascular death, and so was increase in all-cause death with tolbutamide. And because of this reason, the tolbutamide was banned. And even if you today look at a PI of a sulfonylurea tablet, you will find that it contains a black box warning from this trial way back in 1969, that sulfonylurea is associated with increased cardiovascular and all-cause death. Based on this trial, US FDA put a black box warning, which is still present till today. Since in busy practice you never see what is written in PI, so let me remind you, it is still written. Although this should have been now removed. And I'm sure someday US FDA will look back, nobody claims and ask or challenge US FDA. Therefore, I don't know whether it will be removed or not, but this was put in place since 1969. This story did not end here. So I don't want to bore you with the trial. This is basically all the trials done with sulfonylurea. This is not a randomized controlled trial, but observational studies and the pooled meta-analysis of observational studies. So just read the red marked line. These data suggest over the years in a chronological order from 2006 to 2017, all those people who carried out the study suggested that something is wrong with sulfonylurea. And they went in the same direction what UGDP suggested, that sulfonylurea, in that case it was tolbutamide, here as a class, sulfonylurea is associated with an increased cardiovascular risk. You can see majority of the trial. That was the issue. And therefore people were not comfortable, especially cardiologists, should I use a sulfonylurea in a patient with established cardiovascular disease, based on these observational studies. However, if you closely look, some of the data which is there in the fine printing, that among sulfonylurea, so look at the third bullet, they said sulfonylurea, but perhaps except gliclazide. So some signal was coming 14 years back that not all sulfonylureas are same. Some sulfonylurea might be exception to this increased cardiovascular risk through the observational data. So the first one suggested that sulfonylurea associated with increased mortality, but exception being the gliclazide. And this is not compared to placebo, but compared to metformin. If you look, the another sixth bullet there in 2015, again, the gliclazide had not a such signal. Somebody said that it is associated with less cardiovascular death compared to other sulfonylurea, especially glibenclamide. So although sulfonylurea as a class was vindicated, suggesting a cardiovascular harm, but gliclazide was showing some bright signals from the dark tunnel that this could be a different sulfonylurea. However, if you ask me, I am not a firm believer of observational studies for several reasons, and again I don't want to bore you, but just to tell you, in statistics there are a number of biases which generated when you conduct a observational study. So this is a fantastic paper, and the gentlemen, two authors there, they are the father of epidemiology in the world. And they commented, this is a paper published in Diabetes Care, look, all sulfonylureas study put together showing harm. So if you, my pointer is not working, go to the relative risk. All this data suggested that sulfonylurea is very harmful. You can see the HR 1.43, 1.70, 1.37, blah, blah, blah. However, the epidemiologist cautioned that this is because of these kind of bias which happens in a observational trial. So this is a hypothesis generating, but this is not a confirmatory signal that suggests sulfonylurea causes cardiovascular harm. And you should conduct a randomized control trial. So I was mentioning this all HR. So therefore, we need to look at the randomized control trial. And ladies and gentlemen, these are the trials conducted with sulfonylurea till today in the form of a randomized, some of them double-blinded control trial. So you know UGDP that showed increase in cardiovascular death with tolbutamide. Since then, none of the randomized control trial suggested a wrong signal, wrong noise with any sulfonylurea for that matter. And you can see here, UKPDS did not find any problem. In UKPDS, the sulfonylurea used was primarily glibenclamide. UKPDS has started with 2 sulfonylurea, chlorpropamide and glibenclamide. But in meanwhile, while UKPDS was going on, chlorpropamide was banned. So they continued with the glibenclamide. The ADOPT trial, you know, was done with, while comparing rosiglitazone to glibenclamide to metformin. They didn't find any wrong signals. Advanced trial was done with a modified gliclazide release tablet, for the first time suggesting decrease in the primary outcome. And I will come back to this. Record was again done with glibenclamide. You can see here, compared with rosiglitazone, did not find any increase in cardiovascular death. Tosca IT was the Italian study that compared both glimepiride and gliclazide versus pioglitazone, did not find any wrong signals. And Carolina, you know the famous trial we all waited for, where glimepiride compared to linagliptin didn't find any cardiovascular wrong signals. So this was the trial which was final nail in the coffin, Carolina, that came through and suggested that sulfonylurea, glimepiride, is not cardiovascularly harmful sulfonylurea. So in the randomized control trial, we did not find any wrong signals. Now I will quickly take you through this 3 trial that needs, little mention. So let's look at the advanced trial. The advanced trial was a trial which was done with modified gliclazide release tablet compared to placebo in patients with type 2 diabetes. And they compared intensive glucose control done with gliclazide MR compared to conventional control done with placebo or any other molecule other than gliclazide is associated with any cardiovascular or a microvascular benefit. And as you can see, there was a 10% decrease in the, and this was the primary outcome, which was combined measure macro and microvascular component. You can see intensive arm was superior to a standard control. So this is little bit detailed data, and you can see there was a 10% reduction in the composite both macro and microvascular outcome. But this was primarily because of reduction in the kidney event. So that was, you can see, derived from benefit in the worsening nephropathy by 21%. So there was no cardiovascular harm, there was no cardiovascular benefit, but there was a significant reduction in nephropathy, primarily derived from reduction in microalbuminuria, from macro to macroalbuminuria. So this was the first trial done with sulfonylurea using gliclazide MR after the UKPDS and UGDP trial. But there was a caveat, although many people claims that this is a gliclazide trial, so gliclazide is better than glimepiride, but I don't exactly see that this is a gliclazide trial. This is a gliclazide-induced intensive glucose control trial. So when you want to ask whether a good glucose control is better than a poor glucose control, of course glucose control is better than poor glucose control. So that was the question asked in this particular trial. So gliclazide MR should not get the full merit. I would give some marks because it was used, but this trial was not meant to show whether glyclazide is superior to other sulfonylurea. This trial was meant to show whether intensive glucose control is better than a conventional control, although in intensive arm glyclazide was used. The second part is that these are the caveats that they also used different sulfonylurea in the comparator arm. This should not have happened. You would have compared with the placebo. These are the caveats of this study. The second study, again we looked for, was called Tosca-80. This was an Italian trial where people receiving metformin were either randomized to sulfonylurea, either 50% were received glimepiride, 50% received glyclazide, versus pioglitazone. So in this trial we compared pioglitazone versus sulfonylurea. And there was no difference, neither harm nor benefit with sulfonylurea. The intention was to look whether pioglitazone was superior to sulfonylurea or sulfonylurea was inferior to pioglitazone, but there was no such difference and all data was damn neutral, suggesting that sulfonylurea is as cardiovascular friendly as pioglitazone, except that pioglitazone caused increase in heart failure, which sulfonylurea did not. So that was the result of Tosca-80 trial. Finally, this was, as I said, this was a final nail in coffin. The Carolina trial, you know, was a trial, the first trial done with linagliptin compared to sulfonylurea. The Boehringer was a very clever company. All DPP-4 inhibitor did head-to-head trial versus placebo, whereas linagliptin people, those who were maker of linagliptin, Boehringer, they conducted a trial compared with an active comparator, glimepiride. So in the Carolina trial, linagliptin was compared to glimepiride. US FDA said that you can do this trial, but you have to conduct another trial against placebo, because that's the rule of game. To produce cardiovascular neutrality, you have to play with placebo, not with active comparator. So linagliptin has undergone two trial cardiovascular outcome trials. One was Carolina against glimepiride, and one was against placebo, which was called Carmelina. So in the Carolina trial, you can see these are the patients with type 2 diabetes. They were randomized to either linagliptin or glimepiride. And we wanted to know, Boehringer thought that glimepiride would be cardiovascular harmful and linagliptin would be neutral, so we will win the match, but the story goes haywire. And in this trial, there was no difference in composite of 3-point mesh, thereby suggesting that glimepiride is as CB neutral as linagliptin. So this was not a winning situation for linagliptin compared to glimepiride. Indirectly, this was a winning situation for glimepiride, suggesting that it is a CB neutral like linagliptin. And linagliptin again fought with placebo in the Carmelina trial, and it was found to be neutral. So this suggests that glimepiride is as neutral, cardiovascular neutral as linagliptin. And now everybody is convinced after 2019 Carolina trial that glimepiride is a CB neutral drug. Glyclazide already given hint through the advanced trial that there was no harm. Even if you control blood glucose intensively with glyclazide, there was no wrong cardiovascular signal, yet there was a benefit in the kidney endpoints outcome, primarily the albuminuria reduction. However, the Carolina learned a lot of lesson to us. You look at the different endpoint, damn neutral, no signals whatsoever, suggesting glimepiride is a CB neutral drug. So now we learned that if you have got a patient with established cardiovascular disease, if you use glimepiride, there is no likelihood of any worsening cardiovascular event, because 50% patients in the Carolina trial had established cardiovascular disease. Now these are the endpoint data. You can see all damn neutral, p-value all significant. Indeed, if you closely look here, although I don't comment on this, but I wanted to show you that glimepiride seems to have little better edge in terms of heart failure outcome. In this trial, Carolina trial, there was a suggestion that 21% had a higher heart failure in linagliptin arm compared to glimepiride. Although it wasn't statistically significant, but this raises a question that DPP-4 inhibitor heart failure issues still lingers with linagliptin. Although in the Carolina trial, there was no signals with increase in heart failure hospitalization. It was indeed 10% less against placebo. But against glimepiride, there was a 21% trend in increase in heart failure. Although it is not a statistically significant value. The point I am trying to raise is glimepiride is a separate drug compared to linagliptin when it comes to heart failure outcome. Thereby suggesting that that age-old drug which we used for past 60 years, questioned by all Westerners, is no longer existing after the Carolina trial published in 2019. Yes, there was an issue with hypoglycemia. You can see this, taller bar with hypoglycemia with sulfonylurea, glimepiride compared to linagliptin. And this is expected in line that DPP-4 inhibitor per se do not causes hypoglycemia unlike sulfonylurea because of their different mechanism of action. One reduces blood glucose in a glucose-dependent manner. Sulfonylurea reduces blood glucose in a glucose-independent manner. Therefore, the sulfonylurea will cause more hypoglycemia than a DPP-4 inhibitor. However, if you look at the Carolina trial, because Carolina trial compared linagliptin to glimepiride, the glimepiride dose used was little bit, forcefully titrated. We don't do it in clinical practice. We don't increase the dose every monthly. As you can see, for linagliptin, it was a flat dose. For the glimepiride, it was 1 to 4 milligram titrated every monthly. Therefore, it is likely to cause hypoglycemia. Second, if you look at the caveat of this study, 35% of patients had established cardiovascular disease. Many of them were more than 70 years old, where we don't wish to push up the dose of glimepiride to, higher dose every monthly. 18% had CKD, where you are not supposed to use 4 milligram. As you know, it's only 1 milligram is recommended. So this trial did suggest that although there was increase in hypoglycemia with glimepiride, but somehow it appeared that, investigators, including the sponsors, forced people to up-titrate the dose of glimepiride. And that's the reason I wanted to show you, suggesting increase in hypoglycemia. Carolina taught a lot of lesson. We learned that sulfonylurea, earlier it was, when I was a medical student in 90s, I was taught that sulfonylurea loses efficacy. So if you use, sulfonylurea, your patient will fail to achieve a target HbA1c, say within 6 months, 1 year down the line. In fact, my thesis MD was secondary OHA failure. And, we used to taught that if you use sulfonylurea, the glucose control is lost very quickly. The Carolina trial put all the water on those theory. In Carolina trial, there was no difference in glucose control between linagliptin and glimepiride for 6 years. Look at this. So until 6.3 years, both linagliptin and glimepiride were CB neutral, well tolerated, similar durability of glucose control. Had this trial not been done, रोजी यही बोलते कि सल्फोनिलूरिया काम नहीं करेगा कुछ दिन के बाद. सर, दिस इज ए यू आर बीटिंग द हॉर्स विथ ए व्हिप. ये सब टिपिकल डायलॉग हमारे पढ़ाते समय टीचर बोलते थे. यू शुड नॉट व्हिप द सल्फोनिलूरिया, यू गेट ए सेकेंडरी OHA फेल्योर क्विकली. All those are a wrong teaching because we didn't learn the science of type 2 diabetes. Type 2, when we were a student, we were taught that when type 2 diabetes develop, 80% of beta cell is gone. Who told you? Today, after the bariatric surgery, a long-standing diabetes of 30 years reversed with type 2 diabetes. Look at the Adnan Sani, he was 165 kilo, receiving 300 units of insulin. I was his treating physician. He is no longer is having type 2 diabetes. Look at Nitin Gadkari, Venkaiah Naidu. I don't want to tell the name of the people who undergone bariatric surgery. They were 30 years old diabetic receiving 200 unit insulin. They no longer suffers from type 2 diabetes after bariatric surgery, where from the beta cell has generated now. So the entire concept is today reversed of type 2 diabetes. Anyhow, so the point I was trying to make that sulfonylurea seems to work until 6.3 years. They didn't lose to linagliptin. There was increase in hypoglycemia, and this is very likely to happen with sulfonylurea compared to a DPP-4 inhibitor. However, if you closely look at these hypoglycemia requiring hospitalization was not that much higher with glimepiride versus linagliptin. 0.8% only higher. Doctor साहब माथा घूम रहा है, ऐसे ही होता है सल्फोनिलूरिया खाने पर. But you get adjusted. Once your blood sugar is 400, It comes down to 200, your patient will complain. Doctor Sahab, matha ghum aa raha, chakkar aa raha hai. This is not hypoglycemia. This is pseudo-hypoglycemia. You don't need to reduce the dose of tablet. This is not a biochemical hypoglycemia. Hypoglycemia is defined alert 1 when the blood sugar is less than 70. Even if your patient has got a 500 blood sugar with 400 blood sugar, patient will complain of pseudo-hypoglycemia. But what we need to tell, चिंता मत कीजिए, ठीक हो जाएगा आपका 7 दिन में. ऐसे ही होता है जब आपका शुगर नीचे कमता है. We need to explain them. So if you look at this severe hypoglycemia, that wasn't that much higher with glimepiride versus linagliptin. However, if you look at the increase in heart failure, hospitalization due to heart failure, it was proportionately higher with linagliptin compared to sulfonylurea. So I always put this slide in front of those who talk against sulfonylurea. My intention is not to demean DPP-4 inhibitor. My intention is to not demean sulfonylurea. Look at this data. Which one is more important? You would decide, hypoglycemia versus hospitalization due to heart failure. So this was the lesson I learned from Carolina trial, that sulfonylurea is as good, CV neutral, like linagliptin. It works similar when until 6 years, like linagliptin. Nobody should hesitate to use sulfonylurea. And I don't want to bore you with this 3 randomized controlled trial. Let's look at the $1 million question, which people always ask, which sulfonylurea to use? Glimepiride versus gliclazide. So simple answer before I show you the data, if your patient cannot afford gliclazide, use glimepiride. If your patient can afford gliclazide, use gliclazide. If your patient has a tendency to develop hypoglycemia, those who are elderly, having a CKD, or prone to develop hypoglycemia, use gliclazide. Simple. Now, why I said so? Let's look at the data. So this is the only head-to-head trial where 2 sulfonylurea was studied. Rest all of the trial made here and there, in the bathroom pan is all farce. Don't read those studies, observational studies sponsored by pharma company, throw into dustbin. These all are pharma-sponsored, simple observational studies. Throw it to dustbin. The only trial done in planet is called guide study. This was done from Austria. This was a double-blind randomized control trial, as you can see, where 800 plus people were randomized to either glimepiride or gliclazide. So it's a double-blind RCT. Only trial done till today. And you can see there was no difference in glucose control. So koi puche, sir, kaun sa drug acha hai? Glucose control mein both are same. But when it comes to hypoglycemia, you can see there is a 50% less. Look at this graph. There is a 50% less hypoglycemia with gliclazide MR preparation compared to glimepiride. Simple conclusion, no difference in glucose control, but gliclazide causes significantly less hypoglycemia compared to glimepiride. Is it enough evidence? No. Let's look at other evidence. So this is the paper which we published to look at real story, because everybody was making us fool that sulfonylurea is a bad drug, use DPP-4 only. So when you are looking at a hypoglycemia outcome, the biggest issue was hypoglycemia. When looking at the hypoglycemia, what can be a better situation than a Ramadan? People going for fasting for 12 hours, you use the sulfonylurea. If the drug causes more hypoglycemia, you are the bad drug compared to other drugs. So this is the systematic review we published nearly 10 years back, where you can see 3 randomized controlled trials done during the Ramadan looked for the different agent. So the first is, this is the data done from UAE, where vildagliptin was compared to gliclazide, glimepiride and glibenclamide. So 3 sulfonylurea and 1 DPP-4 inhibitor. And look at the hypoglycemia outcome, clearly demonstrating that gliclazide causes least hypoglycemia. Second proof after the guide study in the Ramadan. Second study, this was done by S.R. Arvind from Bangalore. This is a randomized control trial. This is a sitagliptin trial compared with, you can see, gliclazide, glimepiride and glibenclamide. And again you can see the gliclazide has a less hypoglycemia compared to sitagliptin. Look at the second RCTs done during the Ramadan. And third was again done from Dubai by Mohammad Hasnin and group, where they compared vildagliptin to gliclazide. And you can see little higher hypoglycemia with gliclazide compared to the Wilder. So you have got a 3 DPP-4 head-to-head trial suggesting that amongst the sulfonylurea, glyclazide causes least hypoglycemia. There is no doubt to now ask this question after the guide 3 trials done with during the Ramadan period. Now, why sulfonylurea is different? You need to go to the basic, that this is how sulfonylurea works. The glyclazide doesn't possess this benzamoid moiety. You can see all the sulfonylurea in front of you. Look at this chemical structure. Sulfonylurea has got 2 moiety where they binds to the beta cell. The sulfonylurea moiety and benzamoid moiety. If you have got a 2 anchor attached to the beta cell, you are fixed to the molecule. 2 langar dala hua har ek sulfonylurea. Lekin glyclazide has got only 1 langar, only 1 moiety. So it joins quickly and gets up quickly. So it causes immediate blood glucose control and gets back, and that's why do not causes hypoglycemia compared to other sulfonylurea. Second way to understand, all sulfonylurea works through this 2 receptor. They gets attached to the beta cell and gets attached to the SUR1 receptor, as well as this is a EPAC2 receptor. This 2 receptor is important to understand. When they gets bind to the SUR1, this is the classical pathway of sulfonylurea, how it works. But when they get binds to this second messenger, EPAC2, they quickly make exocytosis. Now, all sulfonylurea binds to both SUR and EPAC2. Glyclazide doesn't bind to EPAC2. So again, 1 anchor less here. All sulfonylurea has got a 2 anchor here on the sulfonylurea beta cell receptor, and on their chemical structure they have got 2 anchor. This is the reason glyclazide is a quickly acting drug and quickly getting back to from the circulation, causing less hypoglycemia. So this is what we learned since 1951 to 2025 about sulfonylurea. My understanding, of course, future sulfonylurea is going to stay. Sulfonylurea should not be the first line drug in patients sitting in front of you with type 2 diabetes, with established cardiovascular disease, heart failure and kidney disease. If you find it, patients with type 2 diabetes with a history of MI, receiving sulfonylurea, not receiving a SGLT2 inhibitor and GLP-1, his blood sugar is controlled, stop sulfonylurea. Shift to the SGLT2 inhibitor, or if they can afford to a GLP-1. There is no fact denying that SU should not be the first line drug in a patient with established heart disease, heart failure and CKD. Even if your patient is well controlled diabetes on sulfonylurea and metformin, but not receiving either a SGLT2 inhibitor or a GLP-1 receptor agonist, stop the drug, replace with a SGLT2 inhibitor. Today, a tablet of SGLT2 inhibitor costs lesser than a tablet of a glyclazide molecule. Please do not hesitate to stop sulfonylurea in a patient with established heart disease, heart failure and CKD. That is also the moral of the story. However, once you have used these cardiovascular friendly improving agent, SGLT2, GLP-1, now you don't have any weapons to control blood sugar. At the end of the day, blood sugar has to be controlled. The SGLT2 alone cannot control diabetes in every patient. So is the GLP-1 or so is the combination. So when you need 3rd drug or 4th drug to use, we do need sulfonylurea. So what I learned, if you look at the 2 molecules currently fighting, glimepiride and glyclazide, glimepiride has now proven cardiovascular neutrality in the form of Carolina trial. So the all controversies related to cardiovascular issue, it should be put to rest. No discussion whatsoever. This trial also showed that what had been taught was wrong, that sulfonylurea lost, their durability very quickly. As we learned in Carolina trial, it worked at least 6 years, stand erect, not losing the match for 6 years. There was some issues with hypoglycemia with glimepiride. One has to be careful. As I said, the only double-blind randomized control trial guide suggested that there is no difference between glyclazide and glimepiride when it comes to glucose control, but glyclazide causes less hypoglycemia, nearly 50% less compared to glimepiride. We learned through the observational studies, although with a less evidence, best value. But we also found even in observational studies that glyclazide perhaps has got a least CB issues amongst all sulfonylurea. And we also learned that although in advance it was intensive versus conventional, but the glyclazide best intensive arm had, albuminuria benefit, microvascular benefit. So to me, whatever is your choice, you can choose between glimepiride and glyclazide. When it comes to CB neutrality, the glimepiride has a straightforward data. Glyclazide has got a data through the advanced trial, although that's not exactly the same of evidence like Carolina. But, that was the era of advanced trial. We don't have any future head-to-head trial of any sulfonylurea planned in the future. Now, final suggestion that if you find a patient with kidney disease or patients prone to hypoglycemia like an elderly population, glyclazide must be preferred over glimepiride. That's it from my side. Thank you very much for your patience listening.
Thank you, Avdesh, for that wonderful presentation. I think we have learned almost everything, but after such a wonderful scientific deliberation, it's imperative that we listen to the perspective from the physicians, cardiologists, and nephrologists. So before I open the session for questions, let me have the cardiologist perspective first. Dr. BP Singh, please. Mic dijiye sir ko. And Dr. Avdesh will keep answering the questions.
Wonderful presentation, Dr. Avdesh. I must congratulate you. And I personally, whatever feel and I practice of diabetes, hold with the glimepiride. Not by the guideline, this SGLT2 inhibitor and that inhibitors. My patients are happy. I don't show any more adverse effects with them, as you suggested with the Carolina. This is my personal experience. Not even aware of this Carolina trial suggested this is a cardiovascular neutrality. However, what I learned from my own practice, that these drugs are very cardiovascular neutral and they can be used. What I think about the hypoglycemia, people should not jump using more like 2 milligram, 3 milligram, like start with the lower 1 milligram, titrate the dose. I don't think there is much incidence of hypoglycemia. And this drug is going to stay, and this glyclazide, when Om Kumar, I remember him, kidney involvement is there, always should use glyclazide instead of the glimepiride. And these two drugs are going to stay, as you suggested. Thank you.
Now the nephrologist perspective from Dr. Hemant Kumar.
So, I think it's not a nephrologist perspective. Personally, I feel that many myths have been busted. And what Dr. A.K. Singh has told that sulfonylurea should not be considered as a monolithic class of drugs. Because the older sulfonylureas and the newer generation like glimepiride and glyclazide are very different, like older beta blockers and newer beta blockers. Whatever we are using, personally I am also very afraid of using sulfonylurea in CKD patients, especially stage 5 patients, 4 or 5 patients. But I have learned that, yes, I was aware of Carolina trial that it is severe neutrality with linagliptin, but I was not aware that it causes almost reduction in albuminuria of 24%, of tune of 24%. So this is a new learning, and after hearing your lecture, I think I will tend to prescribe more and more sulfonylureas, especially the glyclazide MR in more patients. So thank you very much for educating us.
After Om Kumar, physician's perspective from Dr. Vijay Acharya.
Thank you, Dr. Avdesh, for an excellent lecture on sulfonylureas. It is quite clear that sulfonylureas, they may not be cardioprotective, but at least cardiovascular safe, particularly talking about glyclazide and to a great extent glimepiride. And in my opinion, all the trials which you have shown, the strongest evidence that sulfonylureas are cardiovascular safe is UKPDS. It is a long, comprehensive trial. It has been followed up for 24 years after that as well. And at that time, at the time of the UKPDS, we did not have any drugs other than insulin, sulfonylurea, or metformin. And there was no increased cardiovascular risk in terms of mortality or morbidity in those who were given prescribed sulfonylureas. So these are the days when you talk of cardiovascular protection and renal protection. Yes, they do not provide that. But then if you want an additional drug, probably sulfonylureas, particularly gliclazide, might fill the gap. Thank you.
Thank you, Vijay. Thank you, Dr. Om Kumar and Dr. BP Singh. Now, before I come to this table of experts, I will open the session to the hall for any question to Dr. Avdesh Kumar Singh for his presentation. Please move with mics there. दूसरा mic use कीजिए.
Thanks for your beautiful discussion. Learned many things new which I didn't know. What I want to know, I want to know two things from you, and then I'll say two more things. Yeah, you have told about gliclazide and glimepiride, which I have been using personally also for last 30 years. Last 30 years, I'm telling you. What do you think about repaglinide? This is also sulfonylurea, short-acting sulfonylurea. What I personally think that the danger of hypoglycemia is more with more long-acting drugs because of the decrease in the blood sugar, of the type of meals that you are used, about 2-3 meals a day. So what do you think about repaglinide? Then I will tell one more.
Okay. So first of all, repaglinide is not a sulfonylurea. Repaglinide belongs to a family called meglitinide. Okay. So that has netiglinide and repaglinide. So they are the class of drug which walks through the sulfonylurea receptor. It works through the same sulfonylurea receptor SUR1. So therefore, one should not use both sulfonylurea along with repaglinide. So netiglinide was banned. There was a trial called Navigator trial where netiglinide was associated with increase in cardiovascular death. And that's why netiglinide was banned. Many of us were using the Glenmark launched the netiglinide at that point of time. The repaglinide is good drug in patients, having predominantly prandial hyperglycemia because it's a very short-acting drug. One can use it, just during meal, even after the meal. However, the only issue is that because of very short half-life for 2 hours, in a 24-hour time, you cannot control blood glucose even with 3 tablets of repaglinide. Although these are very shorter-acting drugs, so preferred in patients with kidney disease. However, the hypoglycemia issues with repaglinide is not at all lesser compared to a longer-acting sulfonylurea. So there are many head-to-head trials that has been done with repaglinide compared to, say, glimepiride or gliclazide, where repaglinide didn't show less hypoglycemia compared to a glimepiride. So this is a general feeling that repaglinide, being a shorter-acting drug, will cause less hypoglycemia, but it wasn't seen in the clinical trials. Now, does that mean that I should not use repaglinide? No. It should be sparingly used in those people who shows, just a prandial hyperglycemia of certain duration. Some day, say, patients with CKD undergoing hemodialysis, but we have got no better tools in hand. If you use, say, linagliptin in a patient undergoing hemodialysis, it will also control a prandial blood glucose like repaglinide. And that's why repaglinide is no longer a popular drug. So the scope of using repaglinide is very less. It is there, people does use, but if you look at the data, repaglinide does causes hypoglycemia. It reduces postprandial blood glucose, no effect on fasting plasma glucose, has to be given thrice 4 times daily, and that's why it's not a popular drug. That's the simple answer.
My second point is that every endocrinologist and physician must tell the patients when you prescribe a drug, what are the symptoms of hypoglycemia? Unfortunately, this is not happening. The patients are not aware of symptoms of hypoglycemia initially unless they suffer from it, and then they have been told. So this practice must be there, that the patient should be told about the features of hypoglycemia, how to counteract it, and how to do this. This is all I want to say. Thank you.
So the propensity to cause hypoglycemia is not necessarily related to the half-life and the duration of effect. As Avdesh had shown very elegantly in one of his slides, that it is the absence of the benzamide moiety number 1 and binding to the SUR1 plus EPAC receptor, which actually drives the incidence of hypoglycemia. So that's one thing which I would like to clarify upon. Yes, any other question from the audience? Or any comments, not necessarily a question? Yeah, Dr. Ravikant Mishra, he is our guest from Jamshedpur. He has also come here to enjoy the Chhath festival like Avdesh is here.
Yeah, I only say regarding hypoglycemia. There is a term called hypoglycemia unawareness. And that all the people, especially long-standing diabetics, they do suffer from hypoglycemia unawareness, which must be told to patients what are the findings of things, or what are the symptoms of hypoglycemia unawareness.
Right. Absolutely, well taken. Yes, Dr. Arun, yeah.
Among all gliptins, which is most suitable to combine with sulfonylurea, and among all glipfazolin, which is suitable to combine with sulfonylurea?
Okay, that's a good question. So, first of all, combining DPP-4 inhibitor to a sulfonylurea is a pharmacological nonsense. Because both the drug works on the same organ, it's like using two sulfonylurea together. You do find one of the top institute in the country writing gliclazide in morning and glimepiride in evening. We do record this, which is absolutely unethical. Now, looking at how both the drug works, DPP-4 inhibitor also stimulates beta cell to secrete insulin. Sulfonylurea also works on sulfonylurea receptor to secrete insulin. Both are insulin secretagogue. Adding two drug doesn't make pharmacological sense. However, we do use in clinical practice, knowingly or unknowingly. Now, I can debate how it can be used and why it should not be used. Now, DPP-4 inhibitor not only works through beta cell, it also works through alpha cell. Sulfonylurea works through only beta cell. So one can argue that if I use a DPP-4 inhibitor along with sulfonylurea, I am additionally taking care of alpha cell, I am reducing glucagon, and therefore I control blood glucose, which is fairly correct. So there is some sense of using a DPP-4 inhibitor with a sulfonylurea. Now, which one to choose? See, we have no option currently between sitagliptin and linagliptin. We don't use any other DPP-4 inhibitor at the moment. We have got vildagliptin, we have got teneligliptin. But if you ask my preference, because of CB neutrality of sitagliptin and linagliptin, both are preferred. That doesn't mean that vildagliptin doesn't work. Vildagliptin is equally efficacious like sitagliptin or linagliptin. Now, there is no special reason to select one DPP-4 over other DPP-4 along with sulfonylurea. Having said that, sitagliptin and linagliptin has got a CB neutral outcome data. Sulfonylurea also has got a CB neutral outcome data. So if you want to choose between DPP-4 inhibitor, choose between sitagliptin or linagliptin. Now when it comes to gliflozins, when you are using SGLT2 with sulfonylurea, that makes a sense. Sulfonylurea working on beta cell, SGLT2 working on kidney, both will working complementary, synergistic. You can choose either dapagliflozin or empagliflozin. There is nothing much between to choose between the two drugs. You can use any of that. I hope I answered your question.
Yes. Dr. Avdesh, I have a comment and a question. As you rightly mentioned that both sulfonylureas and DPP-4 inhibitors, they are cardiovascular neutral. So if you want to have cardiovascular protection, instead of giving this in combination, you should give some drug which has which provides you with cardiovascular protection. What about metformin with a DPP-4 inhibitor?
Okay. So, yeah, that's not a bad suggestion, but it all depends upon whether you believe metformin is a cardiovascular improving drug. I don't believe it. So, to me, metformin, and if you look at the note, nobody believes in this planet. If that would have been the case, metformin should have been the first line drug today, which is no longer there.
It is not.
Since 2020,
it used to be.
It used to be.
Yes.
In the absence of those trials, until 2022, the metformin enjoyed as a first line drug. Since 2023, American Diabetic Association and ESD combined update, metformin is no longer in the list of entire algorithm of today treating type 2 diabetes. Now, everybody believed that metformin was CB beneficial drug based on UKPDS 34 trial, based on 342 patient data, which was, not at all conducive to the current, scenario. So, yes, if we didn't have any tools in hand prior to the SGLT2 GLP-1, because we had nothing in hand, we thought that metformin is the only drug that has the best data. But now we have got a Himalayan evidence with SGLT2 and GLP-1, where metformin 342 data from the UKPDS trial doesn't look at all, conclusive. And that's the reason why all the guidelines in the world has put metformin, into the last segment of treating type 2 diabetes.
Yes, thank you. Audience, okay, there.
Is there any scope of combining sulfonylurea with semaglutide oral?
So you are saying that GLP-1 and sulfonylurea, again, it's the same sense, DPP-4 inhibitor and GLP-1. Both are incretin-based therapy. Both will work in the same direction. You can use it, but then again, there is no sense. If you use GLP-1, you don't need any other secretagogue. There is no powerful secretagogue than GLP-1 receptor agonist today. So even if you combine the sulfonylurea to GLP-1, I don't think there would be a great HbA1c lowering, because GLP-1 does all the things. GLP-1 has beaten insulin in a head-to-head trial when it comes to glucose control.
Yeah.
So we have the problem of recurrent hypoglycemia with sulfonylureas, which can last from 72 hours to 6 days. So how cautiously should we be using this molecule in patients who are in their 70s or 80s? And if a patient develops this hypoglycemia, then what should be the mode of reintroduction of the sulfonylurea?
That's a very nice question. So the good news is recurrent hypoglycemia with the newer generation sulfonylurea is very less. You see the glimepiride trial, Carolina, I gave you the example. In the Carolina trial, until 6 years of using glimepiride 4 milligram, only 4.8% had a recurrent hypoglycemia requiring hospitalization. This speaks volume that the hypoglycemic probability with modern sulfonylurea, including glimepiride, is very less. Having said that, it is not zero, so one has to be very careful. And when we are dealing with a hypoglycemia, needless to say that gliclazide causes significantly less hypoglycemia than glimepiride. So one has to be very careful. The rule of games for sulfonylurea is go with a smallest dose. Regardless of the blood glucose, you start with the smallest dose. As a young physician, you tend to use very high dose of sulfonylurea. When you see a patient with a, say, fasting sugar of 350 and PP of 490, you immediately jumped and put your prescription Amaryl M2 milligram twice daily. This will end in a hypoglycemia. You use the minimal dose. 1 milligram of Amaryl will do blood glucose control in a treatment-naive patient with HbA1c of 11%. So diabetes is learned through experience, not through any textbook. There is no formula written anywhere.
You have to titrate.
You have to titrate with the smallest dose. Yes, sir.
Dr. Santosh.
Sir, want to
say? I have seen in my practice, like more than 500 fasting blood sugar, several patients, and 800 pp. They go, you have told the pseudo hypoglycemia. As soon as you treat dramatically, patient will go in hypo. So you start with lower dose, bring the 800 or 500 with 300 above. And then you try to, remember one patient, his best line of blood sugar was 260. If you bring 250, he will go in a hypoglycemic coma. So, very difficult to...
Yeah, Dr. Santosh now.
Just complementing what Avdesh has talked about, Carolina is there, and the same was echoed in the great trial. The glimepiride was associated with hypoglycemia, but the durability of glimepiride scored over sitagliptin. So definitely it was the same as was seen in the Carolina trial. Avdesh said about the choice of gliclazide when you are thinking of hypoglycemia. The same I would say when you are opting for sulfonylurea in a patient with CKD. Again, it's a scoring point because glimepiride you cannot use with the eGFR of less than 15. Even below 30, it has to be used at a dose of up to 4 milligram. Gliclazide at a lower dose we can use even with eGFR of less than 15. And that was again there in the health-related quality of life study which was done by the JADE, Joint Asia Diabetes Evaluation was there. As was asked about the gliptins and the sulfonylureas, a very interesting aspect over there. When you used to initially talk about the gliptins, you used to talk of the receptors where the gliptins are acting. It is separate from the sulfonylurea receptor, although both are secretagogues. We used to have that line that sulfonylurea failure is not synonymous with beta cell failure. And you can still induce insulin secretion with the use of gliptins. So that was there. The other things, paucity of time or they didn't look at the other aspects because it was a huge topic. The role of sulfonylurea in other types of diabetes. And it's intrinsic to sulfonylurea. You cannot think of management of MODY without sulfonylureas. An interesting thing I would like to share with all this, we know about the primary failure, secondary failure, it's his MD topic was there. Primary failure, sulfonylurea 25% and 5% per year was there. I was going through the primary and secondary failure for MODY 3. And there they have mentioned a very minuscule amount of patients having a genetic mutation, having primary failure. It was to the tune of 1% going over 3 to 25 years for secondary failure of sulfonylurea in MODY. So that was very interesting aspect of the sulfonylureas. Another thing I was going through vis-a-vis metformin, and there was an increased testosterone linked with sulfonylurea vis-a-vis metformin. And then I searched about the mechanistic ways, and they have said that possibly it is related with the higher insulin secretion, stimulating the Leydig cells, and producing testosterone. So that is again one area where sulfonylurea has a scoring point, at least in diabetic patients having some amount of hypogonadism. So all these plus points for sulfonylureas once again.
And to add to that, there is a genetic variety of diabetes which occurs very early in the childhood, maybe less than 1 year of age. In that particular type of patient, only sulfonylurea saves the life. Insulin doesn't work at all.
It's a dense syndrome.
It's a, right.
So diabetes and development and neonatal diabetes.
Right.
And this is because of the sharing of SUR in the brain.
Right.
I purposefully,
yes, Dr. Ved.
I purposefully did not mention beyond type 2 diabetes.
I
don't want to be provocative. I don't want to tell my audience that it increases testosterone. From the tomorrow, everybody will started calling it. So that's the reason I did not put it onto the board.
Yeah, Ved Prakash.
Sir, is there any evidence that shows that metformin worsens the cardiovascular outcome?
Good question. So, answer is yes. Many people doesn't know that metformin induces increase in coronary restenosis. There were many studies that actually indirectly indicated that people undergoing a coronary artery bypass surgery or people undergoing a stent, those receiving metformin against the placebo, there was an increased chance of re-stenosis of coronary artery. So that was there in place. But I don't know why this was not brought into the limelight in the scientific arena. But I did notice that there were some studies that indicated that metformin has a potential to cause re-stenosis after a stent insertion. Having said that, this was tested in BARI 2D trial. Okay, and in BARI 2D trial, as you know, there was insulin secretagogues versus insulin sensitizer. In BARI 2D trial, in patients undergoing a stent or a CABG, people on metformin had no difference in re-stenosis compared to the secretagogue. So that closed the story of metformin associated re-stenosis. So this issue came into the limelight for some time, then went away after the BARI 2D trial.
Sir, I think just like before Carolina, it was postulated that sulfonylureas are not cardiovascular safe. So I think the same story with metformin also. There is no dedicated trial which indicates that metformin is either cardiovascular neutral or cardiovascular safe. So it is very difficult to draw a conclusion that metformin is not cardiovascular safe.
I didn't get you. You want to say that metformin is not cardiovascular safe?
No, no. I want to say that metformin is cardiovascular safe or at least neutral.
Yes, it is there. So that's what
so,
we...
sir, you have told that metformin is nowadays it is not used as a
No, he didn't say that. He only said that it is no longer the first line drug to treat type 2 diabetes. He didn't say that metformin increases the adverse cardiovascular outcome. No, he never said that. And he also said very clearly that the so-called perceived cardiac benefit of metformin is based not on any randomized controlled trial, but 342 patients from the UK PDS subgroup.
I totally agree, sir.
That's all.
I totally agree.
Yes, Dr. Ashok.
For cardiologists, we have only 3 OHA which we believe to having CVOT trials. First foremost is GLP-1 receptor agonist, second one is SGLT2 inhibitor, and third one is metformin. Because you will extrapolate the data from UK PDS, they have shown cardiovascular benefit with metformin. So we cardiologists using these 3 molecules first and foremost, and there are certain molecules like DPP-4 inhibitor. They usually shows no cardiovascular benefit, but they are almost neutral, as you have been already discussed in different parts. And you have shown the trial of GUIDE study. And in GUIDE study, you have shown the reduction in hypoglycemic episodes were 50% lesser with gliclazide compared to glimepiride. But the number of patients was hardly 800 or something like that. So number of patients to draw a conclusion is very less in GUIDE study.
But Ashok, that was statistically powered.
Yeah, sir. One more thing. Powered. Sir has already said that in elderly patients, hypoglycemic episode is less with gliclazide, but there are certain meta-analysis and RCT that has shown that particularly in elderly, glimepiride scores over gliclazide in terms of hypoglycemia. Yeah.
Sorry. So I agree on the first 2 points that for cardiologists, drug of choice is SGLT2 and GLP-1, and it should be. Not having a choice of SGLT2, GLP-1, then means you are not a cardiologist. But why you are so close to metformin is because you have been taught this. If given the choice, if I would have been the cardiologist, my third drug would have been pioglitazone, not the metformin. Please remember, the proactive trial was one of the largest trials done in planet. And the only drug that reduces myocardial infarction was pioglitazone. The only drug that reduces a stroke was pioglitazone. So if you look at the current ADA-ASD guideline, for the past 2 years, the third drug after SGLT2 and GLP-1 is pioglitazone. Pioglitazone came back with a flying colors. Right. I know that because of the concern of heart failure, the cardiologist doesn't prefer it, and rightly so. So if you have got a patient where you feel that this patient may have a latent heart failure, you don't wish to use pioglitazone. But having said that, if you have got a patient who had a history of a stroke, then the first drug is GLP-1 and the next drug is pioglitazone, not SGLT2 nor metformin. So in patients with a stroke, the best data which we ever have is with the now GLP-1 and earlier with the pioglitazone. So pioglitazone has a great role. Metformin, as I said, metformin has been taught to have a good data in UK PDS trial. Someday when you come back to Patna, I will tell you, Dr. Ajay Kumar, I am saying that when someday I come, I will show you the UK PDS diary. That what happened in the UK PDS trial, because many of you were not born during the UK PDS trial. I am sorry to say that UK PDS trial was a master stroke by many of the young endocrinologists, but those who were in the UK PDS trial here, this was one of the most corrupt trial ever done in the planet was the UK PDS trial. It has undergone a 28 modification. The trial was never meant to look for any mortality outcome. The trial was only meant for the primary outcome, which was published in 1998, was to look for whether sulfonylurea reduces blood glucose without causing cardiovascular death. This was the primary outcome of the UK PDS trial. But later on, people keeps on changing their goalpost, and it went on. There were 28 modifications which has happened in UK PDS trial. And I will show you someday what was wrong with the UK PDS trial. But having said that, I am not taking any demerit of UK PDS trial. At that point of time, that was the only gazette which we have. And the metformin giving a CB benefit in a 342 patient, given them the opportunity to use metformin for next 30 years until 2023. So metformin enjoyed that space. Metformin is still used left, right and center. I am not discouraging it, but I am saying that with the given evidence which we have with the SGLT2, GLP-1 and pioglitazone, the metformin goes little last in the queue. That's the point I am trying to do.
Yeah, if there are no more... Yes, you have another question?
Sir, a few words about glipizide, sir.
Oh, so glipizide, sorry sir, it is no longer preferred drug. As I said, in KDIGO, if you look at the KDIGO 2020, there are many nephrologists out here. The KDIGO 22 guideline, I was one of the part of the KDIGO guideline, not being a nephrologist. In KDIGO 2022 guideline, glipizide was put after the gliclazide MR now. So the glipizide was the drug of choice among sulfonylurea in patients with CKD until 2022. In 2022, the KDIGO put glipizide at number 2. So now, in a patients with CKD with eGFR less than 30, gliclazide MR is the first sulfonylurea of choice, followed by glipizide, followed by glimepiride. And glimepiride dose is only 1 milligram. So glipizide no longer enjoys that position which they had in a patients with CKD. Now coming back to the hypoglycemia or other outcome, glipizide of course causes significantly higher hypoglycemia than glibenclamide and gliclazide. Lesser than the glibenclamide, but higher than the glimepiride and gliclazide. So therefore, if you really rank now the drugs, glimepiride equal to gliclazide, larger than glipizide, glibenclamide is no longer, still downhill is there or not. So glipizide now goes to the number 3rd position.
Thank you, Avdesh. Now we are getting very late, so I will have the privilege, being the chairman, to have the last question to Avdesh. And it's a thought-provoking question. Please, ab chhod dijiye. Dinner nahi hoga. You mentioned about the advanced trial, right? And you said that the combined primary endpoint was reduced by 10%, having used the modified release gliclazide and at the same time other sulfonylureas. We should remember that the advanced trial, the patients of type 2 diabetes were recruited who had spent almost close to 10 years following the diagnosis. So my question is not based upon any data, it's a thought-provoking question. If modified release gliclazide is used much early in the natural history of type 2 diabetes, say since diagnosis, would you think that it would have given a much more robust cardiovascular and renal benefit than what we saw in the advanced trial?
That's a nice question. I would rather, put in linagliptin, maybe gliclazide would have been shown a superior outcome than linagliptin. Okay. This is my opposite and a provocative view. Because it was glimepiride and that's why it became neutral. Yeah. Had this been gliclazide against linagliptin, somehow linagliptin would have lost the ground. This is my personal feeling. Yeah. Now coming back to the putting gliclazide in a recent onset type 2 diabetes in the advanced context, it is likely, it is highly possible. If you look at the mean age in advanced trial, it was more than 70 years.
Yeah, yeah.
It was more than, the average mean duration of diabetes was nearly 11 years.
Right.
If the glyclazide would have been used earlier in the advanced trial, things would have been perhaps different.
They carried
And
a very bad metabolic
Absolutely.
legacy. 10 years, 12 years since diagnosis, you are already, completely rotten.
And why it is important to discuss about advanced trial, because in the same era, the Accord Advance in BADT was done.
All of them.
In the Accord trial, there was an increase in death in the intensive arm. The trial was stopped prematurely. Whereas in advance, there was a benefit in the composite primary outcome. This speaks volume that what kind of molecule you use to treat intensive blood glucose control, that matters most. So I believe that your question is very nice. Possibly, yes, if you would have used earlier glyclazide in advance, you might have, get a larger benefit.
Thank you of this very much, and I would like to thank all of you for this wonderful, very, very interactive session. Thanks, Dr. Avdesh, for taking time to come to Patna and to give us such a brilliant presentation, thought-provoking, and generated so much light, not only the heat. Thank you very much. And the last part of the introduction of this, I kept secret in my earlier introduction, that besides number of qualities that I mentioned, he is one of the most outstanding singer. He is a great Kishore Kumar singer that many of you might not know. Thank you very much.
With the permission of sir, I wanted to felicitate Dr. R.K. Mishra, sir. R.K. Mishra, sir.
से पहले खत्म हो गया तो बहुत बड़ी बात है।
नवंबर आने जब से पूरा सीएम 11 बज जाए।
Now, sir, I will request to all of you, please join for the dinner. That is a Chhat special. Thank you, sir. Thank you.
हर महान कार्य की शुरुआत एक छोटे से विचार से होती है और उसी विचार ने जन्म दिया 3 डॉट्स फार्मा को। हमारा उद्देश्य केवल दवाइयां ही बनाना नहीं, बल्कि स्वास्थ्य और विश्वास की नई परिभाषा गढ़ना है। 8 फरवरी 2025 3 डॉट्स फार्मा के इतिहास का स्वर्णिम अध्याय। इस दिन हमारी नई अत्याधुनिक फैक्ट्री का भूमि पूजन संपन्न हुआ। ये फैक्ट्री गुणवत्ता, तकनीक और उत्कृष्टता का प्रतीक बनेगी, जहां हर उत्पाद बनेगा एक बेहतर जीवन के उद्देश्य से। 3 डॉट्स का मानना है, डॉक्टर सिर्फ इलाज नहीं करते, वे उम्मीद जगाते हैं, वे दर्द को समझते हैं और हर नब्ज में विश्वास भरते हैं। हम अपने हर उत्पाद में उस समर्पण, उस करुणा को महसूस करते हैं जो एक डॉक्टर के हृदय में बसती है। डॉक्टर्स हमारे मार्गदर्शक हैं और हम उनके सेवक। हर परिस्थिति में, हर क्षण में 3 डॉट्स हमेशा डॉक्टर्स की सेवा में 24 घंटे तत्पर रहती है, चाहे दिन